So I wanted to do a quick video demonstration on all the different techniques for doing ultrasound guided injections for the shoulder. The big four that I use for the shoulder are going to be long head biceps, tendon sheath injections, AC joint, subacromial injections, and glenohumeral joint injections. Subacromial is going to be by far the biggest, the highest volume one because that's a very common injection, and we'll show some different techniques to do all those things quickly. So I think to start off with, there's a couple different needles you can use for more shallow areas. A 23 gauge 1.5 inch needle works great. It's a small needle. I think the smaller the needle, obviously the less it hurts the patient, but if you're going into deeper areas, you need a little bit larger needle. So occasionally we'll use the 21 gauge 2-inch needle. This is a great needle to get into the joint. Very few patients that I can't get into the glenohumeral joint with a 2-inch 21 gauge needle. This is a great needle to start with. And then for AC joints, I've actually switched to using a 27 gauge 1/2 inch needle. It's a very small needle, but it's shallow, and since the AC joint is so shallow, it's great because you can bottom out the needle. It's tiny, and it's also a very tight space, so you don't need to have a large amount of medication that you're putting in there, so a small needle works great there. So 21 gauge 2-inch needle is the workhorse for deep structures like the joint, or a very large patient for a subacromial space. For biceps, tendon, and most subacromial injections, we use the 23 gauge, and then for AC joints, we use a 27 gauge 1/2 inch needle. So we're going to start off looking at how do we do our biceps tendon injection. So again, elbow at 90, neutral position to find the biceps. Start off in the front of the shoulder here, okay? Get the probe switched. And what you want to do, the way I've switched to doing these is going in axis with the probe, but short axis biceps. So if you look here on the screen, we've got the short axis of the long head of the biceps. If you have the patient externally rotate, what you're going to do is kind of flip the groove out to the side so the needle can come in. And then what you're going to be coming in as, the needle is going to be coming in right from the side here like this. And you're going to see the needle come in, and it's going to go right into the groove right there. So you're here, and always make sure that you're right up on the probe, and you're very precise with this, because really you only have about the width of a credit card in terms of how much you're visualizing the needle. So you come right here, push the needle in roughly 1 centimeter, then find the needle, and then watch it as it goes right into the groove, and then I essentially bottom it out in the groove and then inject the medication. You can also do a long axis biceps. So if you were to come right here, I always tell people go between the two mountains. So that's lesser tuberosity, greater, go between the two. And then you're going to take your needle's going to come right at the top of the groove. And so this is in line with the biceps and also in line with the probe. And so that's the two different ways that I do a long head biceps injection. The next one is subacromial. You're going to have the patient pull the elbow back. You're going to find your anterior supraspinatus view. Very simple. Come in right here, looking right at the shoulder. Tip of the needle comes in right there. And you're going to see the needle come in, and there's going to be a space right here. You see right above the supraspinatus, there's this white line. That's kind of your deltoid fascia / bursa. So you just want to get in that, is a thin, like almost 1 millimeter space right above the tendon that you want to inject the medication. Now, one thing I will tell you is once you see the needle come in, you want to go back and forth with your probe, because you could be not seeing the very, very tip of the needle in space. So you want to make sure that you're seeing the tip of the needle. If you inject and the patient says, ouch, well, you're probably in the tendon, which you don't want to be. So make sure that you see the tip of that needle before you inject, and what you will see is kind of like a hydrodissection. This space will open up very nicely, and it should be essentially a painless injection, and there's no question that you're getting the medication right where the pathology is because you're looking at it. You can also do this through the short axis view if you like. I've tried it both ways. The advantage of this, it's a little bit less awkward for you coming in. I've had trouble seeing the tip of the needle as well this way. This way, if you look, if you're looking at the short axis here, let me go this way. So this is long head biceps. You could come in from the front, you could come in from the back, which this way you'd be seeing the needle coming in from the back if you injected back here like this. So it's a little bit easier on you because you're not having to kind of crouch down, but I've just had a little bit more difficult time finding the tip of the needle on this plane, probably because I just don't do it as much. But the other way works great. You're just kind of having to be, you're way more down in the anterior than you normally would do. Most people do their subacromial injections landmark guided back here, so you're having to squatch down a little bit, but it's not too bad, and it's a great way to do this. Next way is glenohumeral joint. So this is a big one for sure, because I think most surgeons agree that some sort of image guidance is going to improve your accuracy for this. So a lot of different ways to do this. You need to go a little bit deeper on your machine. So we see right here, here's your humeral head, rotating here, here's the triangle of the labrum right there. So you can come from lateral, okay? And if you do that, you want to actually bring your probe as medial as you can. We're going to go a little deeper. bring your probe as medial as you can so that your angle is steeper. The more shallow your angle, the tougher it is to get into the joint. You're also injecting, you're going more through the tendinous portion of the cuff, which hurts more on the patient's side. So you want to try to bring the probe as medial as you can, and bring the needle's going to come straight down from here. You can also just find your joint, put it right in the center of the probe, and then you can go center line. The advantage of that, it's a little bit easier technically if you go through the center right here and see your needle come straight down. You just can't see the tip of the needle as well, and you kind of have to guess how far up you have to come in order to see it go in, but you'll get into the joint really easily that way. And then the other way to do a glenohumeral joint is medial, coming from the inside right here, and then what you'll see is the needle coming in right down this line here. I think all three ways work well. Just figure out which way works best for you, and they're all effective. Invariably, when I teach courses on this, people ask me about going in from the front, because very typically when you do an arthroscopy, you place the scope in the shoulder, and then you put a spinal needle through the rotator interval portal. The caution that I have people telling me that is, it's very easy to put a needle through the biceps tendon as well as the upper subscapularis in a patient because you don't have the joint full of water. So the rotator interval is much more narrow than you think in a dry shoulder, so to speak. And so it's very easy to hit one of those structures, and it's quite painful for the patient. So can you get in from the front? Yes. Is it considerably more painful because of structures that you can hit with your needle coming in than from the back? Absolutely. And I've tried that technique, and I've switched back to doing it this way because it was really uncomfortable for the patients if the needle goes through the upper subscapularis or the biceps tendon. The last one we're going to look at, actually we're going to look at two more, is going to be the long head it's going to be AC joint. So AC joint injection, you basically just find your AC joint right here. We're going to go super shallow because it's a very shallow area, and then you're going to come in. Here's the joint right here. So here's the end of here's the acromion, here's the clavicle. We're going to take the needle and come straight center line right through in the middle of the probe right there. Okay, and then all you're going to see is the tip of the needle in this space here. The second way to do that is actually an interesting way. Alan here, Hard taught me this. So you find the end of the clavicle right here, and you come till you see darkness. So once you see dark, then you're in the disc of the AC joint. So here's the end of the clavicle. We go just to where, and then right here's the acromion. So in between that space is going to be your, let me flip so we're right. In between that space is going to be your AC joint. So you find the end of the clavicle, here's the bone, you lose the end of the clavicle, and then what you do is you actually go in line with the probe, so right here in the front, and you'll see your needle going into the AC joint right here, right through there. And it's a very easy way to do it. And again, I use the 27 gauge for this, unless it's a really large patient, because I know that the needle is going to bottom out right in the center of the joint, and it's a really small needle for a really small space, so that works really well. So I've actually switched to doing this technique. The last injection that we're going to talk about is suprascapular nerve. So suprascapular nerve is an injection that we use for frozen shoulders. It's a great way to help anesthetize the shoulder before they do a stretching session with a therapist. And so the way that you find that, you're coming right off the posterior aspect of the acromial spine right here, and you've got to go fairly deep into the shoulder. And so here's your supraspinatus fossa right here. And what you're looking at is kind of this U at the very bottom. Let's see if we can get a better view here. It's essentially right here, you kind of see this dip in the bone. Well, that's the suprascapular notch. And so what you're doing is you're going to take the needle coming right here medially, and you're basically just going to drive it down all the way here, pull back a little bit. You can actually see the vessel beating right here. That's the suprascapular artery right above the ligament. And so right below that's the nerve. You're going to see the needle come in, pull back a little bit, and then load this space up with some local anesthetic before you do a manipulation of the shoulder in the office for frozen shoulder occasionally. So those, I said 4, but they're really 5 main areas that we inject under ultrasound. I think it just takes practice and time to learn how to do this, but once you kind of get your system down, I think it's going to be great for you, great for your patients, more importantly. The other thing I stress to everyone is really learn how to do these on your own. And people say you use sterile gel. I don't use sterile gel. What we do is the patients all the gel's wiped off. You put local anesthetic on the patient where you're going to inject. You put gel on the probe. Then don't drop your needle. but you uncap your needle, have your probe held, and then you're not injecting through the gel, you're injecting through the area that's been cleaned with alcohol swab. So there's really no need to have an assistant or someone helping you. I think if you learn how to do it that way, then you're not slowing your office down, you're not pulling your assistant into the room to do that, which saves a lot of time, and you know, the more time you can save yourself, the more apt you're going to be to do this. So I think really learn how to do them on your own. You don't need to use sterile gel because you're not injecting through the gel. It does take a little time to learn how to do it, but it's worthwhile for sure to learn how to do that. So thank you very much.